We'll go to the third speaker, Dr. Anushree Naidu. You'll be speaking on anterior segment migration of the Ozurdex implant through the surgical PI.
Good afternoon, everyone. Today I'll be speaking on anterior segment migration of Ozurdex implant through surgical PI, a rare complication. Ozurdex is a biodegradable dexamethasone implant that uses NAIDU drug delivery technology, in which the biodegradable material is paired with an active drug. Intravitreal injection of Ozurdex is routinely used for the treatment of cystoid macular edema associated with epiretinal membrane diabetic retinopathy and intraocular inflammation. Anterior segment migration of intravitreal Ozurdex implant is a rare complication, and it is reported in 0.63 to 1.6% cases. It leads to complications like secondary corneal decompensation and refractory corneal edema. In patients with incipient corneal edema, urgent removal of Ozurdex is mandatory. 65-year-old female presented to us 2 years ago with a history of nucleus drop during cataract surgery done elsewhere. We managed the patient with pars plana vitrectomy, phacofragmentation, and a SFIL was implanted. Patient gained a best corrected visual acuity of 6/18 and 10 2 months post-operatively. However, 6 months after the surgery, the patient came to us with decreased vision, and on examination, we found that she had developed an ERM with CME. Her BCVA noted that time was 6/60. We started the patient on conservative medication with topical and oral steroids, and the patient showed improvement in the 1 month period after the starting of conservative treatment, and also the vision had improved. We continued the conservative treatment. The neurosensory detachment had resolved completely, but the CME persisted in 2 months post-operative period. After waiting for 3 months, there was a refractory CME, and the CME had increased again. Then we decided to inject the patient with Ozurdex implant, and the patient underwent the same. However, 3 weeks post the injection, the patient presented to us with diminution of vision and a BCVA of counting finger 2 meter. The slit lamp examination revealed the anterior segment migration of Ozurdex with the corneal stromal edema. This is the image of AIOS showing the CCT of 887 microns, and this is an AIOS image through which the section is showing Ozurdex in the anterior segment. An immediate explantation of Ozurdex was done, and we decided to observe the patient for corneal edema. Corneal edema was managed initially conservatively with topical and oral steroid cycloplegics and topical hyperosmotic agents. The edema persisted for 2 months even after the conservative treatment. However, the CME had resolved completely. After the 2 months, we registered the patient for DMEC. After a waiting period of 3 months, the patient ultimately underwent DMEC. And the slit lamp photo, this is showing 1 week after the DMEC surgery, and patient had gained a 6/24 and 12 vision by then. At 2 months post-op, the patient gained a 6/12 and 10 vision with AIOS showing normal cornea and thickness CCT of 522 microns. The OCT macula showed complete resolution of CME that was present even then. Anterior segment migration of intravitreal Ozurdex is a very rare complication. Corneal decompensation is the dreaded outcome of the same. Prompt removal of Ozurdex is the key to prevent corneal decompensation. And in our case, despite early removal, the patient had a corneal decompensation and ultimately required treatment. With appropriate management, ultimately the patient gained a BCVA of 6/12 and N10. To conclude, I would like to say that in cases of ERM with CME in vitrectomized eye, which is resistant, Ozurdex remains the treatment of choice for management. However, the caution should be taken regarding the anterior segment status, any large surgical PIs, any posterior capsular length, or any zonular weaknesses in such patients while administering the same. Thank you.
Why this implant was gone into the anterior chamber? What are the mistake that has committed?
Sir, actually the PI was slightly centrally located. It was a large surgical PI, and when the implant slightly reduced in size, it migrated through the anterior segment. And apart from that, it was an SFIL patient with no posterior capsular support, and hence there was a higher chance of such complications occurring.
So the corneal decompression was very much in this case.
Yes.
That's why.
Yeah, it was like present at the presentation. The patient actually presented to us 2 days after she experienced DOV, and by that time the corneal edema had increased a lot.
What was the reason for waiting for 3 months for DMAC?
Sir, initially we tried managing with the conservative management, and the cornea also, suitable cornea was also not available during that time for the transplantation. And we decided to manage the patient conservatively. She was improving slightly. We were waiting for it to subside on its own, but it was not happening, and that's why in the end we took the patient for DMAC.
What about the intraocular pressures?
The intraocular pressure were stable throughout initially. After the DMAC, the patient had experienced a rise in IOP, but it was managed very well with topical and oral agents or drugs, and the patient remains stable. Now the IOP is stable.
How long you have followed this patient and what was the last visual recovery?
So the complete visual recovery last was 6/12 and N10. The patient has been followed up now for 4 months after the DMAC surgery. The total duration of follow-up of the patient from the beginning is around 2.5 years.
Now, in
From
an
the-
eye in which, can I?
Yeah.
In an eye which has undergone a vitrectomy, which is better, intravitreal triamcinolone or Ozurdex?
Ma'am, both the options are there, but
One is better, definitely I'm
Yeah,
giving you again.
triamcinolone is safer in the way that it won't come into like this, but then it can also come into the anterior segment. And the other thing is that it won't be there for a longer time in a vitrectomized eye. So Ozurdex will stay for a longer duration, and hence the profile that efficacy would be there.
In case of triamcinolone, the secondary glaucoma is more common rather than
because,
Ozurdex.
because it will migrate and it can cause the blockage of the meshwork also.
Thank you.